Yes, ma'am, we are live now, ma'am. Please start.
Yeah.
Ma'am, can I start? Hello.
Yes, yes.
Can I share my screen, ma'am?
Yes,
Who's
ma'am.
asking?
Yes, ma'am.
Ma'am, Neha.
One second.
Actually, I'm not
Sahili, can
able
you
to.
please-
Yeah.
Neha, ma'am, please wait. We will start with welcome address and then you can
Okay,
start.
okay, got it.
Yes, ma'am. Sindhuja, ma'am, you can start.
Kunde ma'am, Sharat sir will do the welcome address.
Yeah, you can introduce Dr. Sharath and start the welcome address. Yes.
Good evening, everyone. Welcome to Tapisar Journal Club, which happens every fourth Wednesday from 8 p.m. to 9 p.m. every month. I request the president of Tapisar, Dr. Sharat sir, to kindly give the welcome address.
Yeah. Thank you, Dr. Sindhuja. Good evening, everyone, and I welcome you all for today's Journal Club meeting. And I thank Dr. Kundavi for selecting the topic of dual stim because 1/4 of our patients for ovarian stimulation will end up in poor ovarian response. In this dual stim, the ovarian physiology is beautifully manipulated to our advantage. So we'll listen to these experts. What do they say? Thank you, Dr. Kundavi, for giving me this opportunity. I request you all to proceed further. Thank you.
Sindhu, you can introduce Kannagi ma'am.
Okay, okay. Kindly share Kannagi ma'am's CV, please. It's our pleasure to invite Dr. Kannagi ma'am for being the chairperson for the first session today. Madam is the director of Tamarai Fertility Center and she's graduated from MMC. She's a very, very senior and she's been practicing ART since 1993. It's a great honor to have you with us, ma'am. And like Kundevi ma'am said, thank you for accepting our invitation and being the chairperson for today's session. I request you to introduce Dr. Shweta and the speaker for today, Dr. Neha.
Thank you, Kundavi, for that nice introduction. It's very nice that you guys, Tapisar is organizing the Journal Club, and it's becoming a very regular event, which is much needed, the Journal Club, to everybody's benefit. And today we have a very nice topic where the duostim is going to help the people, the patients with ovarian reserve. And we have on our panel Dr. Shweta Mittal-Gupta, who's co-director and unit head, Center 5E of Human Reproduction, Sri Gangaram Hospital, New Delhi. She's a professor of GRIPMA, Secretary General-elect of the Indian Fertility Society, editor AOGD, credited for the first pregnancy from the first frozen oocyte, North India. She's a recipient of many awards, including the Economics Times Award for Audition and Gynecologist in IVF, Vigyan Vardhan Award, Dronacharya Award for Oxyethicon Traveling Fellowship, and the first fellow of the National Board of Reproductive Medicine. So a very accomplished person here who's going to give her expert comments on the topic. And we have Dr. Neha Khatri from, can you display her thing, please? Yeah. The topic today will be RCT comparing dual ovarian stimulation, that's duostim, with two conventional ovarian stimulations in poor ovarian responders undergoing IVF. So it's a very new outlook into the poor ovarian responders. And we have Dr. Neha Khatri. Can you get her the slide back again? Dr. Neha Khatri.
Good evening, ma'am. Yes, ma'am, I'll start sharing.
Yeah, please.
Good evening, everyone. I'm Dr. Neha Khatri, and currently I'm pursuing F&B in reproductive medicine from Sir Gangaram Hospital, Delhi. So the topic for today's general club is the BISTEAM study, a randomized control trial comparing dual ovarian stimulation to two conventional ovarian stimulation in poor ovarian responders undergoing IVF. This article was published in Human Reproduction in the year 2023, and this is a renowned journal with an impact factor of 6.1. This study was conducted by Messin et al. In 2023. As we all know that in IVF, the chances of live birth is correlated with the number of oocytes retrieved. Women with poor ovarian response have lower chances of conceiving even after several IVF cycles. And the timing of events is also an important matter as the reserve of the oocyte decline with age. Even a short period of postponing IVF decreases the chances of live birth, especially in older women. Hello, ma'am, am I audible?
Yes, you are audible, Neha. You're pretty clear.
Okay. Oocytes with equivalent quality and competence can be obtained in both follicular and the luteal phase. And equivalent competence of the oocyte demonstrated by a similar euploid blastocyst rate or by an equivalent implantation and live birth rate in a lot of non-randomized studies. And they have proven that the recruitment and the sensitization of follicles in the follicular phase of the stimulation increase the selection of follicles available on the second stimulation. In poor ovarian response women, this potentializing effect may be of great interest as two stimulation in the same cycle can give a higher number of oocytes in a shorter time compared to two consecutive conventional stimulation. So the primary objective of the study was to compare the cumulative number of oocytes retrieved in women with poor ovarian response using duostim, that is stimulation in one menstrual cycle, follicular phase followed by luteal phase versus two consecutive conventional cycles. And the secondary objectives of this study was to compare the stimulation parameters, time to the second oocyte retrieval, live birth rate, and to compare the cumulative clinical pregnancy and live birth rate between the duostim and the BISTEAM group. It was a multicentric open labeled RCT, and it was performed in 4 IVF centers in France from September 2018 to March 2021. The inclusion criteria were women with poor ovarian response were defined with adjusted Bologna criteria, that is at least 2 of the 3 following criteria, that is AFC less than 5 or AMH less than 1.1 nanogram per ml. This criteria was mandatory. And out of second and third, advanced maternal age more than 40 years or more, and third criteria was less than 3 oocytes in previous stimulation. So the age which they included in this study was 20 to 41 years of age, BMI between 19 to 32 kilogram per meter square, and those who have not undergone more than 2 previous IVF cycles. Exclusion criteria was women with amenorrhea and women with FSH more than equal to 20 international unit per liter or AFC less than equal to 1, and women with a partner with an extremely severe sperm anomaly or sperm donor use. All these patients were excluded from this study. So the intervention was that they started with pre-treatment with 70 beta estradiol 4 milligram per day, starting 7 days before the expected date of menses, and they continued it till the menses. And for the first stimulation, the protocol used was antagonist protocol. Starting dose was HMG 300 international unit per day at fixed dose, and the antagonist was added when the leading follicle was more than 14 mm or the estradiol level was more than 500 picogram per ml. So they used flexible antagonist protocol. Trigger used was Ovitril 250 microgram, and the oocyte pickup was done 36 hours after trigger. And then in the control group, that is in the BISTEAM group, ICSI was performed with a fresh transfer And luteal phase support was given 600 milligram of natural progesterone if fresh transfer was done, and all the supernumerary embryos were cryopreserved and consecutively transferred before the second ovarian stimulation. While in the duostim group, all the mature oocytes were vitrified after the first ovarian oocyte retrieval. It was done because when this study was designed, there was a protocol in the France that all the oocytes will be vitrified. And second ovarian stimulation cycle was started the day after in the luteal phase. So for the second stimulation in the duostim group, they again started with the same dose, gonadotropin 300 international units per day. No antagonist was used in the luteal phase. Instead of antagonist, they used natural progesterone, that too after 7 days of stimulation until trigger. And they used Ovitril as trigger. And on the day of the second oocyte retrieval, the cryopreserved and the fresh oocytes were pooled to perform ICSI, and all the embryos were frozen. Embryo transfer in this consecutive spontaneous cycle was done with a modified natural cycle with luteal phase support. This is a flowchart showing the same thing that in the duostim group, for the first stimulation in the follicular phase, they used a flexible antagonist protocol. Then the next day, they again started with the HMG 300 international unit, and the vaginal progesterone was started after 7 days of the gonadotropins. And all the oocytes which were retrieved in the first stimulation were vitrified. And then the fresh and the frozen oocytes were inseminated with by ICSI, and all the embryos were vitrified. And then frozen embryo transfer was done in the natural cycle. And in the control group, first stimulation was done in the follicular phase. Flexible antagonist protocol was used. Fresh embryo transfer was done. And then the supernumerary embryos were cryopreserved, and then subsequent frozen embryo transfer was done. And second stimulation was similar to the first one. So women included in randomized were around 88. So in the control group, that is bistim group, there were 44 women, and the duostim group also, they recruited 44 women. However, 3 were excluded because of the various factors, like the one patient did not meet the inclusion criteria, one had ovarian cyst, and one had spontaneous pregnancy. So only 41 women were subjected to the first ovarian stimulation, and in one patient there was premature ovulation, so she was excluded. And only 20 patients could undergo second ovarian stimulation. 20 were excluded because there was unexpected good response in 9 patients. In 5 patients, there was live birth in the first transfer, because in the control group, they did fresh transfer also. There was consent withdrawal for 3 patients, loss of follow-up for 1 patient, and spontaneous pregnancy in 1 patient. And finally, they could only 17 patients could undergo second oocyte pickup, because 3 patients were also excluded because of no ovarian response. Then coming to the duostim group, they started with 44 patients, and 5 patients were excluded because of consent withdrawal, COVID, and spontaneous pregnancy. So finally, for first stimulation, there was 35 patients were there, and for second stimulation, only 29 patients were there. For statistical analysis, quantitative variables were described by mean and SD values, and the analysis was presented by intent to treat all the women who started the first ovarian stimulation, and when not notified per protocol, women who completed 2 oocyte retrieval. And student t-test was performed to compare the deviation between the 2 treatment groups, and other endpoints were compared by their mean and proportions. Chi-square test or Fisher test was performed to compare the proportions. So coming to results, the demographic data of the control and the Dostim group was comparable with regard to BMI, age, the cause of infertility, basal FSH and AMS values. It was not statistically significant. The difference between the two groups was not statistically significant. Then coming to the first ovarian stimulation, the number of patients in control group was 41 and Dostim group was 39. And the days of stimulation, dose of gonadotropin, and the number of oocytes retrieved in both the groups were comparable. However, in Dostim group, they vitrified all the retrieved oocytes. And the fertilization rate, obviously, it was less in the Dostim group because they inseminated the oocytes which were retrieved during first stimulation after second ovarian stimulation in the luteal phase. And the total embryos were also formed were less in the Dostim group, which was statistically significant. Then for second ovarian stimulation in the control group, there were 20 patients, and in the Dostim group, there were 32 patients. And another significant finding was that time to second oocyte retrieval in months for control group was 2.8 months, and for Dostim group, it was 0.3 months, which was statistically significant. And time to second oocyte retrieval month without COVID interval intervention was also higher in the control group. And with regard to days of stimulation, dose of gonadotropin, number of oocytes retrieved, metaphase 2 oocytes, it was comparable between two groups. And the other finding, which was statistically significant, was the devitrified oocytes, which was obviously it was higher in the Dostim group. There was only one patient in which in the control group where they did vitrification of oocyte. Rest in all patients, they vitrified embryos in the control group. Coming to the cumulative cycles, which was the primary objective of this study. So between the control and the Dostim group, they found that the total cumulative number of oocytes, it was comparable in both the groups. And however, the only clinically significant finding was that the cumulative clinical pregnancy rate, that is positive heartbeat, it was higher in the control group, and in the Dostim group, it was 17.9%. The reason could be this, that in the control group, the number of the embryo transfers were more because they did fresh transfers also. And and secondly, because they vitrified the embryos during first stimulation. So this might also be the cause for poor fertilization rate in the Dostim group. So the present study failed to demonstrate a superiority of Dostim regarding the cumulative number of oocytes obtained and mature oocytes. And this is the second RCT comparing Dostim to two conventional antagonist protocol with the patient treated with comparable fixed dose of gonadotropin, the same number of days of stimulation and the same ovulation triggering. This is the second RCT. The first RCT was conducted by Cerillo et al. In 2022. And the aim of the study was to validate Dostim strategy as good alternative to two consecutive controlled ovarian stimulation in poor ovarian response patient with PGT-A. Their sample size was 80, and they concluded that, that there was similar number of euploid embryos and the duration of stimulation and the number of M2 oocytes in both groups. However, the time to obtain a euploid embryo will be less in Dostim group. So present study was an open label RCT. Patient and the physician were not blinded to the study protocol, and to prevent bias regarding the primary outcome, that is total number of the oocyte retrieved, strict registered protocols with fixed dose of gonadotropin in both the groups were used. Criteria for HCG triggering was also fixed, and the standard procedure for the oocyte retrieval was used. And the study failed to demonstrate any difference in the number of oocytes retrieved from follicular and luteal phase stimulation, thus hypothetically potentializing effect of FSH on the recruitment of early antral follicle is not demonstrated in this study, at least for a short HMG exposure. And similar results were found in the studies done by Lee et al. In November 2022 and Cerillo et al. In 2022. So these are the studies on duostim. Lee et al. Conducted a retrospective study where they compared the pregnancy outcomes between duostim and 2 consecutive mild stimulation in poor ovarian responders. Sample size was 281, and the similar number of oocytes were retrieved in the follicular and luteal phase of stimulation. And Kuang et al. In 2014, they conducted a prospective study. Sample size was 38, and they found that more number of oocytes were retrieved in luteal phase of stimulation. While Varielit et al. In 2018, they did a multi-center experience and SWOT analysis, and the aim of the study was role of duostim to maximize the number of oocytes retrieved from poor prognosis patient. And they also found that the LPS resulted in the higher mean number of oocytes collected than FPS with comparable competence. So the results regarding the duostim protocol is more or less confusing, because in some studies they found that the LPS resulted in higher mean number of oocytes. However, the number of RCTs comparing the duostim protocol with 2 conventional ovarian stimulation are very less. So the strength of this study was second RCT comparing duostim to 2 conventional ovarian protocol, and they used the standardized uniform protocols for follicular and luteal phase stimulation, and identical gonadotropin dose and trigger was used. But the limitations were small final sample size, and the RCT was impacted by the COVID pandemic, and the unexpected poor ovarian response and pregnancy of the first oocyte retrieval in both groups, with higher incidence in the control group. And there was undefined criteria for trigger administration in FPS and LPS, follicular and luteal phase stimulation, and oocytes were vitrified. This was the major limitation of this study, that oocytes were vitrified after the first stimulation and then thawed after luteal phase stimulation for pooling, which itself can decrease the number of usable embryo available. And the randomization and the criteria for starting luteal phase stimulation in duostim group was not described in this study. So to conclude, this study concluded that based on the number of total and mature oocytes retrieved in women with poor ovarian reserve, there is no benefit of duostim versus 2 consecutive antagonist cycle. However, in routine practice, the benefit of duostim in patients with poor ovarian response regarding fresh embryo transfer is not confirmed. Firstly, because this RCT demonstrates no improvement in the number of oocytes retrieved in the luteal phase after follicular phase stimulation. And secondly, because the freeze-all strategy avoids a fresh transfer with avoids a pregnancy with fresh transfer after the first cycle. However, they concluded that the duostim appears to be safe for women, and in duostim, the 2 consecutive process for freezing or thawing are mandatory, which is the major limitation of duostim protocol, and it increases the risk of wastage of oocytes or embryo. The only benefit of duostim is to shorten the time to a second retrieval by 2 weeks if accumulation of oocytes or embryo is needed, like in patients where fertility preservation is required if they are undergoing gonadotoxic chemotherapy. In those patients, duostim may be a fruitful approach. And this study was reviewed and critically appraised by Obaldi et al. In August 2023, where they found that the study design of the they found that the study design was not appropriate, because the authors are not comparing 2 ovarian stimulation strategy, but they are also comparing 2 different settings, such as fresh oocyte insemination versus oocyte accumulation via vitrification, and fresh versus vitrified warmed first embryo transfer strategy. Moreover, this sample size is also limited, and the oocyte vitrification performance that was around 81.6%. And the competence level for the oocyte vitrification performance is around 95%. So it was less. It is below the benchmark value at reference centers. This is already a matter of concern because the oocyte vitrification protocol per se is underperformed. So obviously, the fertilization rate in the duostim group would be less. And indeed, differences were reported by Messin et al. In 2023 only in the duostim arm between the two paired cohorts of oocytes. The first cohort being the vitrified warmed, where the fertilization rate was 66%, and the second cohort being fresh, where the fertilization rate was 79%. Even more concerning, the implantation, cumulative positive heartbeat, and the live birth rate, they all were lower after duostal stimulation, most probably because of this oocyte vitrification thing. To conclude, I'd say that we need more randomized controlled trials with uniform protocol, vitrification protocols, and fixed dose protocols to compare between the duostim and the biostim group. Thank you, ma'am.
Thank you, Neha. You can stop sharing.
Yes, ma'am, I will.
Yeah. So, Neha, see, we have seen this RCT. Now, let's critically analyze, because we were in an era where, we were doing, or we used to consider that only follicular stimulations are the answer of embryo pooling, right?
Yes,
So, my first question to you is that what did we learn from dual stimulation?
ma'am, dual stimulation is an effective strategy in patients where, like in those patients where fertility preservation is the main thing, and poor responders, Poseidon 3 and 4 patients, where those patients who might require multiple ovarian stimulation, in those patients, duostim strategy will be effective, where embryo pooling is the main aim.
And why does the dual stim seem to work? What is the meaning of dual stim? So
Dual
what is
stim in one
basically the follicular event happening? That's what I want to know.
Ma'am, the new theories are coming up that there is continuous recruitment of the follicle in one menstrual cycle. So whenever we'll give patient gonadotropin, the new cohort of follicles will emerge and it will start growing. So the basis for duostim strategy is that there is continuous recruitment of the ovarian follicle. So based on this theory only, duostim strategy was developed. In duostim, what we are doing is that in one menstrual cycle, we are stimulating the patients in the follicular as well as the luteal phase.
So could you elaborate? So now leave aside this study, the SWOT analysis. Let's do the SWOT analysis of dual stimulation itself. So if I talk about what are the strengths when it comes to having back-to-back two stimulations in the same menstrual phase?
Ma'am, dropout rates will be less. Patient will be only in 1 month, the patient might be able to retrieve more oocytes, and so embryo pooling can be done in dual ovarian stimulation, ma'am.
So, like, for example, I just want to put forth some clinical scenarios. So I get a call from USA yesterday, and this girl will go through her 4th or 5th ovarian stimulation cycle. She's a poor responder. And she says that I only have 1.5 months with me and I'm coming for a very short duration. So do you think, now I want to offer her, she's 40 years old, I want to offer her an IVF with PGTA cycle. So do you think duostim will be a good option for her?
Yes, ma'am. Duostim is a better option in patients where time is the main problem, because like in this study they have shown that within around 4 weeks they were able to do the second stimulation, whereas in conventional ovarian stimulation it took around 3 months between the two stimulations. So
okay, so one strength was that it was making use of multiple follicular waves in the same menstrual cycle. The second strength was that you could club more embryos in shorter duration of time. And the third strength of the study or this protocol is that the dropout rates are minimum, because ultimately in this Poseidon group 3 and 4, embryo pooling helps. We know by going through the algorithm of the expected rates of euploidy that for women who are more than 35, you will need to club more embryos so as to have one euploid embryo, right? Now, what are the weaknesses? One, you said that, yes, they cannot go through any fresh embryo transfer cycles. What
Yes,
are the
ma'am.
other
These all
weaknesses?
strategy. Secondly, ma'am, sometimes the patient does not respond to the gonadotropin. There are poor ovarian response, and however, in this study, they found that the duration of the dose and the duration of the gonadotropin was comparable between the duostim and the biostim group. But in other studies and in a study which was conducted at our center, they found that the total dose of the gonadotropin and the duration of the gonadotropin required in the duostim group was longer in comparison to the second conventional stimulation. So, which might lead
So
to
in
the
order to overcome this, what strategy did we do? So earlier we were also starting at 3 days post oocyte aspiration, and then we realized that that is taking a longer time, and we resorted to 5th day, because that is the time where we expected that all the corpus luteum would be going through demise and a new follicular wave would be emerging at that point of time. So can you elaborate the study which was published, our study in JHRS? What was it looking at?
ma'am, uh, in
Our
that
study.
study, yes, ma'am. Duostim, Poseidon 3 and 4 patients were included in that study. And in those patients where the MH value was less than 1.1 nanogram per ml. And in that, the patients, they underwent 2 ovarian stimulations, and the gonadotropin was started from day 3 of the first oocyte pickup. And
Yes, we started from.
we compared the number of oocytes retrieved in the follicular phase and the luteal phase, and the total dose of the gonadotropin required, the duration of the gonadotropin required, the number of embryos formed in the follicular and the luteal phase. So it was a
So we
comparison.
basically, chose one group where there was no embryo conversion in the follicular phase, and these patients were subjected to a luteal phase stimulation, and in about 60% of patients we found that there was an embryo formation in the luteal phase. So those poor responders who failed to form an embryo or have suboptimal embryo numbers in the follicular phase is a good option to go through a luteal phase with minimal dropouts. Right now, there are 3 questions in the chat box. If you can answer that, follicular versus luteal phase, which one was better? In your study, they could see that both the phases fared better, and even Obaldi's group, they found, because it was PGTA cycle, and they found that the embryos formed from luteal phase had equal number of euploid embryos when they compared it to the follicular phase.
Yes, ma'am.
Dr. Neha, do you want to add something to this question?
Yeah, ma'am, in both follicular and the luteal phase, they found that the number of M2 oocytes were also comparable in both the groups. Even in first RCT that was conducted in 2022 by Cerello et al. In patients with advanced maternal age, those who were undergoing PGTA, in that also they found that the number of M2 oocytes were same. However, the time to obtain a euploid embryo was less in duostim group in comparison to the 2 conventional ovarian stimulation.
Okay, the
Only
next question
advantage
is,
they
yeah.
found.
So looking at follicular wave, can we start this program without waiting for periods?
Yes, ma'am. We are starting it like in this study, Messin et al., in the study conducted by Messin et al., they started the second stimulation next day after the first oocyte retrieval. And in our center, we start from day 3 or day 5.
So the reason we did not start immediately post OCR, because we saw that it is taking a longer time, especially when we were starting after 3 days. So we gave that 5th day because it is almost theoretically like beginning of second follicular wave, but the patients have not, gotten their periods yet. And all the corpus luteum are on the demise. So that will shorten the duration of your gonadotropin. The next question is that for dual stim, do you do any blood tests before starting the second cycle?
Yes, we do, but they are of least value
No,
because
no.
for-
So I beg to differ. We don't do any. So I can answer that because we have done over 300 cycles. We don't do any blood test monitoring before the start of the luteal phase. We don't do any ultrasound monitoring. They are basically shifted over to medroxyprogesterone. So there are two things which are done. Suppose you wish to even consider a fresh embryo transfer, you can start them on micronized progesterone. By the time the patient reaches day 5, you know whether they have formed blastocyst or not. And if they have less blastocysts, then you can we change over to medroxyprogesterone because it's a cheaper substitute. And we start the second dose of gonadotropin. We give it for 7 days continuously, along with 10 milligrams of medroxyprogesterone. And it's only after 7 days of gonadotropin we call the patients for first monitoring, which is ultrasound and estradiol levels.
yes.
I can
Yes,
also
ma'am.
answer
After
this. Maybe, yeah, Neha.
after 8 days, yes, ma'am. We call
Yeah.
the patient after 8 days, and then we do
So,
the
this question I can answer that adding letrozole, we tried adding letrozole in the luteal phase, and we found that it was causing accelerated follicular growth, but the embryo conversion was not very optimal. So, after a few cases, we stopped letrozole along with the second dose of gonadotropin in the luteal phase. I think we'll take up 2 more questions before we head to the next topic because one more is remaining. Any mention of quality of oocyte in the luteal phase? Neha, can
Yes,
you?
ma'am. Yes, ma'am. They said that in both the groups, the number of M2 oocytes retrieved were equal in both the groups.
Yes, this definitely was the fallacy of this study because they did oocyte freezing. But in our, practical scenario, we do make embryos and we do embryo freezing so they become comparable.
Yes, ma'am.
Yes, in the luteal phase, the embryo quality was comparable. In fact, in our study, we took those patients where in the follicular phase, there was failure to have a blastocyst formation. And that is why in the luteal phase, we found that there was significant improvement.
Overall blastulation rate or the odds of obtaining a good quality blastocyst was much higher, statistically higher in the luteal phase.
Yeah, if medroxyprogesterone can very well be started from the day of oocyte retrieval, if you have already thought that yes, for sure she will go through a second stimulation, which is a luteal phase stimulation, then yes, you can very well start from the day of oocyte pickup. So Gaurav is the chief embryologist in the lab, and he can have you can get some inputs from him from our study, which was done and published in JHRS very recently.
Shweta, when we add medroxyprogesterone, then again it's freeze-all cycle, right?
So dual stim will always be freeze-all because the endometrium is out of phase.
Like a random start. So patients who don't have time, and we were talking about patient who's coming from US.
Yeah.
So can we do like a random start 2 cycles
yeah.
too?
Yes. So, this is what I do, that I just do random start. Like a girl, PCOS girl came and she was 10 or 11 days of age. Absolutely, the ovaries were quiet. So I just started. So many occasions I do a random start because I know these are freeze-all cycles and we absolutely have no issues.
So
I
you
have a
don't
question
use
for
antagon
Dr.
at all, other than the medroxyprogesterone. You don't use antagon.
So basically, you can do either. You can do either. In Obaldi's group, they used like an antagon cycle as a regular luteal phase, the way they did it in the follicular phase. And they used a 2:1 combination of FSH and LH. So they were using pergoveris. But you can use any. You can use a pure recombinant FSH. You can use an HMG cycle. You can use a pergoveris cycle. And you can use antagonist in the follicular phase. And you can also use antagonist in the luteal phase. Our only thing was that we could reduce on the number of injectables, and medroxyprogesterone was bringing a beautiful LH suppression. So we resorted to medroxyprogesterone, how they did it in the Shanghai protocol.
So, Shweta, even you are using medroxyprogesterone for donor cycles nowadays, right?
Yeah.
You don't use and antagonist is not required then.
So ideally not. Sometimes they bring a lot of suppression of LH. So in some cycles I use antag too. But you can actually use PPOS protocol in freeze all cycles. So Dr. Kunzvi, can we move on to the next topic?
Yes, Shweta. Thank you so
Shweta,
much.
and thank you, Tapisar, for
Shweta, the message I got was from, it is good for probably the cancer chemotherapy patients, which is proven. But for the other groups, we are yet to prove that duostim is good enough. Am I right?
So, Dr. Kaniki, I would say that if the time is less and definitely the dropout rate is less, and if you want to pool your embryos, then it's a good protocol. The basic thing what dual stim has taught, that this is a doable protocol. And within yes, it's a doable protocol with same number of oocytes and good embryo conversion. So we need not bother about it.
Chemotherapy patients, and also for those from overseas. But other than that, it stands to be proven. Am I right? That's a take home message.
So that is why we wait till day 5, because we get an opportunity to see the blastocyst conversion. And if they are decent enough, then we don't,
proceed to
Yeah.
Yeah, thank you.
Thank you, Dr. Shweta.
Thank you.
And, thank you, Dr. Neha, as well. Lovely presentation.
Thank you.
Ma'am, shall we move on now? Okay. Thank you for the great session. We'll move on to the next session. For this, I'd like to introduce the chairperson, Dr. Sasikala. Madam has done her MBBS and Masters in Clinical Embryology, and she is the first Indian certified by the American College of Embryology. She has a vast experience of over 32 years and 22 years in ART, and has worked in several countries, including the US, UK, Middle East, and India. I request you to introduce the speaker and expert for this session, ma'am.
Yeah, thank you, Ma. Thank you for that introduction. I'm happy to introduce our expert today, Dr. Gaurav Majumdar. He has a master's in clinical embryology from the National University of Singapore. And then he received his PhD for his research work in pre-implantation genetic screening. And currently he is the lab director at Center of IVF and Human Reproduction at Gangaram Hospital. Over to you, Dr. Gaurav.
Yeah, hi, thank you.
Yeah.
So
And we have our speaker, we have our speaker, Dr. Aditi Sarkar, who's a IFS fellow at Gangaram Hospital. Aditi?
Yes, ma'am. Thank you for the introduction. May I start my presentation?
Yeah.
Yes, please share your screen.
Is it visible to everyone?
Yeah.
Yes.
Good evening, everyone. I'm Aditi Sarkar. I'm currently pursuing my master's in clinical embryology, and I'm an IFS fellow for embryology at Sir Gangaram Hospital.
Louder, please, Aditi.
Okay, ma'am, sure. I'll be presenting this paper by the lead author Antonio Capalbo. The paper is titled Mosaic Human Preimplantation Embryos and Their Developmental Potential in a Prospective Non-Selective Clinical Trial. This was published in December 2021 in the American Journal of Human Genetics. So why is it important for us to know about mosaicism? Aneuploidies are a leading cause of embryonic implantation failures, pregnancy loss, and congenital defects. The uniform aneuploidy found in the entire embryo are usually due to mitotic errors in the oocyte, but the mosaicism that we find in embryos is usually due to post-fertilization mitotic errors. Giving rise to cells of different lineages. Understanding the incidence of mosaicism and distribution of aneuploid cells throughout the embryo is important because genetic testing of pre-implantation embryos and prenatal fetuses is carried out respectively on a trophectoderm biopsy or sample or a placental tissue originating from it, and it is important to know how representative that single sample is of the entire blastocyst. In cases of mosaicism, in this we have found that aneuploid cells are usually localized, and further they are eliminated in the post-implantation stages. In this study, they have detected mosaicism through PGTA testing. So there are essentially two main parts of the study. The first one is to understand the incidence of mosaicism and analyzing the prevalence and clonal distribution of aneuploid cell in a given mosaic embryos. And the second part of the study was to understand the developmental potential of low to medium mosaic embryos in a multi-center, double-blinded, non-selection trial involving consecutive IVF with blastocyst stage PGTA treatments, followed by a frozen euploid, low-grade or medium-grade mosaic single embryo transfer. So, to start with the first part of the study, where we look at the incidence and prevalence of mosaicism. For studying the incidence rate, they took the data of 6,766 trophectoderm biopsies. This was historical data, and the biopsies were then proceeded by next generation sequencing to detect, and this procedure could detect mosaicism of as low as 20%. So essentially, 20% of the cells in the sample need to have mosaicism for the NGS to be able to detect it. Now, the second part of the same, to study the prevalence and the clonal distribution, a different set of embryos was taken. 91 embryos were donated for research, and prevalence study was done on that. So for the incidence rate, the 6,766 embryos were studied. The mean maternal age was 38 years, and the incidence of diploid euploid mosaicism, which included low, medium, and high grade mosaicism, was found to be 18.7%. As we could see in this pie chart, 12.3% was low mosaic, 4.8% was medium mosaic, 1.6% was high mosaic. So total the prevalent incidence rate was 18.7%. And further, they found out that the shorter embryos, like beyond chromosome 15, the shorter chromosomes beyond chromosome 15 were showing the most mosaicism or aneuploidies. Now, for the prevalence study, 91 embryos were donated for research. Now, for these 91 unselected embryos, the biopsy was done for each single embryos in 5 parts. So each embryo they divided into 4 trophectoderm section and 1 ICM section. They were able to make this division successfully for 75 of the 91 embryos. Further, useful NGS data was only gathered for 73 of the 75 divided embryos. So they used one of the TE biopsy as reference, and they found out that the chromosomal abnormalities in ICM were found to be extremely rare and not statistically different, irrespective of whether the reference biopsy has been classified as euploid, low, or medium grade mosaic. I will further explain this with the help of this heat map. So they compared 73 embryos and 22 autosomes in all of the 73 embryos, and essentially four combinations were done. So the TE2 was compared to TE1, the TE3 was compared to TE1, the TE4 was compared to TE1, and then the ICM was compared to TE1. So here TE1 is the reference trophectoderm sample. So there were a total of 6,424 comparisons. So what they found was, on the left-hand side of this heat map, it shows the classification of the reference TE. So if the reference TE was euploid, found out to be euploid, then there was a 99.6% chance that the ICM was normal and all the other trophectoderm samples were also normal. At the same time, if the reference TE was low mosaic, then also there was a 99.3% chance that the ICM was normal as well as all the other trophectoderm samples were also normal. On the other hand, if we look at a high mosaic, if the reference TE outcome was found to be high mosaic, then there was only a 15% chance that the ICM would be normal and all the other trophectoderm samples would also be normal. Rather, there was a high chance, a 65% chance that ICM as well as all the other trophectoderm samples would be abnormal. So, this was the first part of the study showing the incidence and prevalence of mosaicism in embryos.
Aditi, just also explain what if the TE1 was found to be aneuploid?
Okay, sir. If the TE1 was found to be aneuploid, there is a 98% chance that the ICM would be abnormal as well as the other trophectoderm would also be abnormal. Essentially, if the reference TE is abnormal, then the entire blastocyst, if the reference TE is aneuploid, then the rest of the blastocyst is also aneuploid. There is like a 98% chance of that. So there is only like
So
less than 2%.
yeah, so you explain this.
So,
Sorry for that.
so what do I need to explain again?
You explain to them the significance of this finding.
Okay, sir. Yes. So, based on these results, they're like transferring a high mosaic or aneuploid blastocyst is not recommended because there is only less than 2% chance that the ICM would be normal. So it's moving on to the next part of the study, which is to study developmental potential of low to medium mosaic embryos. So this was so the intervention that they did was they did trophectoderm biopsy followed by NGS sequencing, and the low and moderate mosaicism was blindly reported as euploid. And then single embryo transfer was conducted based on standard morphological characteristics. But there were three main groups. Group A was euploid, Group B low to medium mosaic, and Group C medium grade mosaic. Then they did follow-ups for post-transfer, gestational, and postnatal stages. The chromosomal status was found out for 38 newborns because that was only the part of the population that gave consent. And on the newborns, they performed single nucleotide polymorphism array in the saliva samples of the newborns and their parents. The inclusion criteria of the study was, of the prospective trial was the female partner should be aged below 45 years. They need to use their own oocytes. All the oocytes had to undergo ICSI, and at least one transferable euploid or medium to low grade mosaic embryo should be available for transfer. The exclusion criteria was if the women had a history of any unilateral oophorectomy, recurrent spontaneous abortion, diagnosis of PCOS, any uterine abnormality, if the women had any chronic medical condition such as endometriosis or any autoimmune disorders, couples in which the standard karyotyping showed an existing numerical or structural mosaic abnormalities in either of the partners, individuals showing unstable illnesses or medical conditions such as cancer or severe obesity, and only embryo available was of the poor morphological grade. So they recruited 1,259 couples. Out of those, 69 were excluded because they did not fulfill the inclusion criteria. Out of the 1,190 couples enrolled, they underwent 1,603 IVF cycles. Then 41 cases were excluded due to no fertilization, and 225 were excluded due to no or poor blastocyst development. A total of 1,337 PGTA cycles were conducted, and 2,874 blastocysts were biopsied. If the mosaicism was less than 50%, then they were reported as euploid. Further, 490 cases were excluded because all the blastocysts were aneuploid, and 23 were excluded where the embryo available was of the worst morphological grade. They did 897 single embryo transfers, and post-transfer raw PGT data analysis distribution. So 484 SCTs were done for uniploid, 282 for low mosaic, and 131 for moderate mosaic. Further, the postnatal follow-up was done for 11 cases of euploid, 18 cases of low mosaic, and 9 cases of moderate mosaic. The result of the data, the primary outcome they did was implantation rate and live birth rate, and the secondary outcome was miscarriage rate and loss of intrauterine pregnancy. So what they found out was there was no evidence of affected live birth rate among the euploid, low mosaic, and medium mosaic group, and there was no difference in the miscarriage rate as well. There were total of 52 miscarriages, out of which they tested 4, and for side
I think
by
you should show the
standard.
table. Just show the table. Yeah.
So here they have compared the euploid, low grade, and medium grade groups for the positive pregnancy test, which are like 55% for all the groups. Biochemical pregnancy loss rate, which is 10% for group euploid, 12.3% for group low mosaic, and 13.7% for medium mosaic. Miscarriage rate, which was 12% for euploid, 11% for low grade, and 12.7% for medium grade. Live birth rate was also found to be equivalent. The gestational age of the baby was also found to be equivalent, and so was the birth weight. The only thing was they also did gestational examinations, out of which they found one sample, one embryo with of the chorionic villi sampling showing placental mosaicism of trisomy 22, but that was also from the euploid group. And one baby was born with Beckwith-Whitman syndrome, but that is a hypomethylation issue which is not detected in PGTA. And the postnatal genotyping did not show any karyotype errors, and there was absence of uniparental trisomy. So, what they concluded in the study was that the evidence from this trial did not support the cascade of procedures commonly triggered by the reporting of mosaicism in PGT-A testing cases, like genetic counseling, intensified anxiety or distress to the individuals, increased adoption of invasive prenatal diagnosis, etc. There was a positive predictive value of mosaic embryos that was only found in a single case till date. And there is no understanding of clinical outcome if we transfer a high grade mosaic embryo, but transferring that embryo will also be unethical because there is a 65% chance that the entire blastocyst would be affected. And also, not transferring these embryos would not have such a big effect on the live birth rate because the incidence rate of high mosaicism is only 1.6%. The data in this trial is of raw NGS data, and it is independent of specific diagnostic algorithms that are used by genetic testing clinics nowadays. And these findings only concern or anything to find why an embryo shows mosaicism or how the mosaic cells are eliminated. But the data does support the existence of an early developmental bottleneck event that is able to normalize the mosaicism initiating in the post-zygotic aneuploidies in human embryo. Thank you.
Gaurav, will you be talking to her? Any questions?
Yeah, so in a nutshell, what is the most important take home from the study, Aditi?
That we can transfer low and medium grade mosaic and get healthy babies without any genetic abnormalities.
So when you get for example, if we get a trisomy 5 low mosaic report for an embryo, what does that mean?
That from the sample that we have given, like 20 to 30%
Say for
cells.
example, let's say if you get a 30% low mosaic report for trisomy 5. Can you explain what this report means?
So they have found that the like 30% of the DNA content show.
No, first you explain what does 30% mosaic mean to everyone.
The 30% of the cells have the mosaicism from the given sample that we have sent for testing.
No, you tell me what does 30% trisomy 5 mean?
That chromosome 5 has shown trisomy in 30% of the cells that has been sent
Say
for
I
the
gave
testing.
say we gave 10 cells in biopsy.
So
Then
like
what does
3
that
cells
mean?
showed trisomy 5.
Yes. So 3 cells got a reading of being aneuploid for chromosome 5
Yes.
for having trisomy,
Yes.
but the rest 7 cells came up with a normal reading.
Yes.
Okay, so this means that both aneuploid and diploid cells were present in those 10 cells which were given as biopsy, out of which 7 cells were found to be normal and only 3 cells were found to be abnormal or completely aneuploid, right? So such a result is known as a mosaic, which has both cell lines, one aneuploid and one completely euploid. So when you get this kind of a result, then the study suggests that
That the rest of that there is a 90% chance that
Not
the rest of
90,
the
not
embryo,
90. What was the
the
figure?
99%.
Yes.
Yes, sir. There's a 99% chance that the rest of the embryo is euploid.
Yes. So there's a 99.3% chance that the remainder of the embryo, where all the other, because we suspect this when we see a low mosaic embryo, then we wonder that if we found few aneuploid cells in one trophectoderm sample, is it possible that the aneuploidy is also present in other areas of the trophectoderm, or if the aneuploidy is present in the ICM also? So this whole study was done to understand if that result from that single trophectodermal biopsy is an accurate representation of the remaining embryo or not. And so they found that if, say, for example, so the example that we just talked about, if hypothetically out of 10 cells, only 3 cells were supposed to be aneuploid, then there's a 99% chance that that aneuploidy in those 3 cells is localized to only that piece of trophectoderm, and it is not present anywhere else in the embryo. And then through, preferential allocation, or through all the different mechanisms that you mentioned, the preferential allocation or the others also, where there's selective apoptosis, these aneuploid cells will get eliminated. And they have shown a direct evidence that whether you transfer a low mosaic embryo or a medium mosaic embryo or a complete 100% euploid embryo, the live birth rate is absolutely same. And neither is the miscarriage rate increased. So there is no risk of miscarriage also. And there is no risk of biochemical pregnancy loss. And there is absolutely same likelihood of live birth.
So, Aditi, I have a few questions for you. In your opinion,
Yes, ma'am. Yes, ma'am.
do you think meiotic errors will be more uniform or mitotic errors will be more uniform?
Meiotic errors will be more uniform.
Meiotic?
Meiotic errors, like meiotic errors in the oocyte, lead to a uniformly euploid blastocyst.
Aneuploid
Yes.
blastocyst.
Aneuploid blastocyst, sorry.
Okay.
Aneuploid.
In this study, they have shown positive pregnancy in all the groups 55.8, 55, and 55.9. Now, this is a multi-center study.
Yes, ma'am.
There are different embryologists, different clinicians, different settings. Everything is different. So, in your opinion, how possible do you think it is to get a very close values like this? You think it's possible? Because if you see in one group, the euploid group is 55.8, and the low mosaic or the moderate mosaic is nothing much more. It's 55 and 55.7. It is only 1 decimal difference.
Aditi, can you move to the result section?
Yes, sir.
Yeah, show the table that she's referring to. Yeah.
See, you see the positive pregnancy test here. In group A,
Yes,
it's
sir.
55.8. The next group is 55, and the next group is 55.7. So with such
Yes.
a large multicentric study with so many variables, I am a little skeptical about if you can get the exact same result. I don't know, others can speak for themselves. This is my opinion. And the other thing I wanted to ask is, how important do you think is turnaround time in PGT? In other words, if you want to do this study, anything different you will do?
Anything different I would do? No, I'm not sure.
Does freezing induce any errors?
Ma'am, all these embryos were frozen.
Correct.
Whether,
They're all frozen and thawed, yes. So I'm asking you,
yes.
will it be any different if you do fresh transfers and see, or fresh rebiopsies and see, or you think it'll be okay, it'll be the same if you do fresh or frozen? In other
Ma'am,
words, does freezing induce any chromosomal errors in the embryos?
ma'am, I've not seen it, not from my center as of now, but I have very little experience of working. So,
Okay. Okay. Thank you so much. That was a nice presentation. Sindhuja?
Yes, ma'am. Dr. Gaurav, would you like to add any more points? So would you also like to add your experience about transferring mosaic embryos?
Yeah, we have transferred a few, and we've just had the first live birth with the first embryo that was classified as mosaic has delivered a baby with us. We have transferred not many because, see, the prevalence of mosaicism is still very low. But now it is clear that these mosaic embryos have the developmental potential of these embryos is same as euploid embryos. So, this makes genetic counseling much easier. There's a very important paper which helps us counsel the patients properly, because otherwise there was a lot of confusion. Even the geneticists did not know what is the true, potential of these embryos, and then they would land up doing amniocentesis in all cases where, if we'd ever transfer a mosaic embryo, then this is game changing for those patients where there are no other euploid embryos. So what do we do? If there's a mosaic embryo, do we throw it in the dustbin, or do we tell the patient that no, these embryos are safe to transfer? So by that way, this is a very important study. As far as the veracity of the data is concerned, this is a multi-centric trial which has been performed in multiple centers in Europe. The numbers are different. This is just a pure coincidence that the percentages have have been found to be similar, but all the numbers are
No,
absolutely
but if you
different.
see, Gaurav, all the numbers are same. Test sets, positive pregnancy, no, not test sets,
Test
positive
sets are
pregnancy,
different. Test
biochemical
sets are all
loss, miscarriage, live
test
birth.
sets. No, they are
Even
not
the
the same.
monochorial twins delivery is one in each.
Yeah, but they are not same. They are not identical.
I know, but
Because this is
how?
I would think that this is a coincidence that the live birth rate is there's 43.4% in euploid embryos, 42.9% in group B, and group C has 42%.
Hmm.
So this could purely be a coincidence.
Yeah.
And as far as your question of freezing the embryos is concerned, freezing is now considered to be, especially vitrification, is the standard of care. And it's perhaps the only way to go about doing a PGTA cycle, because most PGTA cycles involve biopsying embryos both on day 5 and day 6. And if you, like we routinely biopsy embryos only on day 6 now, so then it makes a fresh transfer impossible to
That's what
perform.
I'm saying. If the turnaround time is much lesser, so that we will be able to decide on, the fresh embryos, then most of these errors could be excluded. I mean, it's going to take a long time by the time, but
No, but one of the most important prerequisites of performing PGTA is having a very robust vitrification program. And
that's because their turnaround time is long.
no, but turnaround time cannot be turnaround time cannot.
Why are we freezing embryos here? Only because they are not able to give the result immediately, right?
No, also because we are biopsying embryos on day 6, and when we do that, then transferring in the fresh cycle is no longer viable, and we know that transferring in a frozen cycle will give us much higher pregnancy rates.
Yes,
So
Gaurav,
what
that's
the
exactly
maximum is.
I'm saying. We have to improve our protocols. This PGTA, we should be able to do it earlier. We should be able to get the results earlier, and then this will be much more effective. It's a long-term vision,
But as it
hopefully
is,
it
they are
happens.
showing that it is very effective, right? We are obtaining a live birth rate of 43%, and the age group of these patients is what, about 38 plus
Correct, correct.
minus.
But maybe we can improve it better. We can get even better
So
results.
if we can achieve in a poor prognosis, advanced maternal age group, if we can achieve a live birth rate of 43% per single euploid embryo.
Sorry, I had one doubt there also. They said 73% of the study population has advanced maternal age, but their AMH mean is 2.8.
Where is it? Can you go back, Aditi?
I assume most of them will be above 40 years or so. And then AMH apparently
Where
is
is the
2.8.
no, not here, not here. Where are
The
you?
demography of patients, I think. It's
No,
in
show the, not the result of the first study, the second study.
So they have not mentioned AMH anywhere.
they have in
Can
that
you go back?
supplemental tables,
Can you go back?
demographic data of couples
Just
enrolled
go
in the
back.
trial.
Go back.
It's not in my PPT. I don't think.
Here. Have they mentioned here?
No, it's in the supplemental tables.
Go further back.
I think she has not included that here.
Yeah, it's not on my PPT.
It's not in your PPT, but they have
It's
mentioned.
in the article, sir. It's not there in the PPT.
Okay, what does it say?
Says the AMH mean is 2.8 plus or minus 2.9, but the maternal age here they say is advanced maternal age. 73% are older. And the second point is they've also included surgically retrieved sperms. Of course, all these are going to add on to the errors in chromosomes. But anyway, thank you so much, Aditi. That was a nice presentation. Thank you so much. Sindhija, can we wrap up?
Thank you, Gaurav, and thank you, Aditi, for a nice presentation. Learned a lot.
Right.
Yeah, Sindhu?
Yes, ma'am. Ma'am, I kindly request you to give the vote thanks for today.
On behalf of Tapisar and Dr. Sharath and Dr. Radha, we congratulate Dr. Shweta Mittal and Dr. Gaurav Manjab team, Dr. Aditi and Dr. Neha for a wonderful presentation and expert comments from Dr. Shweta and Dr. Gaurav. And thanks to chairpersons Dr. Kannagi and Dr. Shashikala for their expert opinion as well. And thanks the team for giving us the opportunity for this journal club. Probably every month we would like to have this sort of journal club the last Wednesday. And thanks to Shield who has given us this online platform. Thanks Sindhu for coordinating the people. Thank you so much. And thanks for staying with us during the dinner time as well.
Thank you. Thank you.
Thank you. Thank you.
Thank you, Dr. Kundavi and Dr. Sindhija, for your wonderful way of conducting this